Before I introduce our speaker, I have a few announcements to make. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabsom Department of Geriatric Medicine. At this time, please enter the name and credentials of people viewing Grand Rounds for CME attendance purposes. As a reminder, you will need to complete an evaluation to get CMEs. You can find the evaluation by following the link in the chat at the end of this presentation, or on our email advertisement, or on our website. Your comments are very important to the planning committee and will be used to plan future programs. As always, speakers are asked to disclose their conflicts of interest, and Dr. Yim has said he has no conflicts of interest with regards to this presentation. It is my great pleasure to introduce Dr. Michael Yim. He's proud to be the only born and raised local boy to graduate from UH Jabsom and obtain a residency and fellowship at the Bascom Palmer Eye Institute, which is ranked the nation's #1 eye hospital for the past 2 decades. As an assistant clinical professor at Jabsom, he enjoys sharing his experience with current and future physicians of Hawaii. Through Jabsom, he continues to perform research, and he publishes articles ranging from the evaluation of certain types of eye cancers to potential new treatments. With his most recent article on the treatment of neovascular glaucoma published just last year. That's pretty amazing, Michael, considering I know you're a very, very busy clinician. So congratulations on that. He also serves on advisory boards, offers consultation for pharmaceutical and medical device companies, gives talks across the nation, and is involved in a national prospective clinical trial focusing on minimally invasive glaucoma procedures. He currently serves on the board of directors for the Homeless Outreach Medical Education Project, Jabsom's home clinic, through which he helped establish the first free ophthalmology clinic for the underserved community. He's also a board examiner for the American Board of Ophthalmology. Please join me in welcoming Dr. Michael Yim.
Thank you so much, Dr. Masaki, for that introduction. And thank you all for being here. I'm just trying to see how I can minimize this. Okay, perfect. So can I start?
Yes, please.
Okay,
Go ahead,
perfect.
Michael. All
Perfect. So
yours.
yeah, so I'm Mike. I'm here at Queens. I'm in private practice in Queens POB1, and I'll be talking to you guys today about glaucoma. And so, yeah, no significant financial disclosures for today. I do, as Dr. Masaki mentioned, I talk for several different companies that do glaucoma drops and or surgical devices, but I'm not going to be talking about any of those devices in particular today. I was born and raised here, and today we're going to talk about the basic eye anatomy kind of relevant to understanding glaucoma. And so, in general, we'll talk about what glaucoma is, why should this matter to you, the natural history of this disease, and the treatment options, because I think they're vastly different from when you guys were in medical school and in residency to what we have now, because it was so different when I was a medical student to now how we practice our treatment of glaucoma patients. And so, the eye, if you think about it, is like a camera. So it's a very highly specialized camera. There's a lens. Then that lens is something that eventually turns into a cataract as you get older. And that light is focused on the film of your camera, which is your retina. And that retina will then send a photo to the brain through the optic nerve. And the optic nerve is kind of like the HDMI cord that connects your computer monitor to your computer that transfers all the information from your eyeball to your brain. And what glaucoma is a chronic progressive disease that damages your optic nerve. And so there was a common misperception, even as a medical student, and even as a first year resident, I thought that glaucoma was just pressure that was high inside the eye, and then the high eye pressure damages the optic nerve, and that's how people go blind. But there are actually many, many, many different types of glaucoma, and the most common type of glaucoma here in Hawaii is actually normal tension glaucoma, where people do not have high pressures. They always had pressures under 21, which is the normal number, but they have this chronic progressive optic neuropathy, which is called normal tension glaucoma. And so why we care about glaucoma is that it's the leading cause. Well, I guess depending on what sources that you read, but either AMD versus glaucoma, but most recently glaucoma is the leading cause of irreversible blindness in the world. There are so many people that have glaucoma all over the world, and 3 million in the U.S. And a lot of people call it the silent blindness because for the most part, glaucoma is painless. Unless you have acute angle closure, 99% of glaucomas, they're painless. You don't feel high pressure in your eyes, just like a diabetic doesn't feel the high sugars in their bloodstream. The vision loss starts in the periphery and then gradually tunnels in. So the vision loss in the mild, moderate, and the early severe stages are imperceptible to the patients. So it's not like somebody sees this big black area in their field of vision. Their brain is really good at ignoring that area and filling in a virtual image of what it thinks should be there. So some people come in 90% blind, they're looking through a small little pinhole and they have 20/20 central vision. They'll swear to you they have nothing wrong with their vision. And then you hold your finger up, they're like, how many fingers? And they're like, what finger? What finger? And then that's like the aha moment that they don't have any peripheral vision. But it's not something that they notice. It's very imperceptible to them and it's painless. And so that's why it's very early. So it's very important that we diagnose the disease early and we treat it early. And if as long as we diagnose it early and we treat it early, we can slow down the rate of progression to hopefully have that patient live a long, healthy life without worrying about blindness. But if you catch it at 90% damage to the nerve, well, we're just slowing it down to save that last 10%. We want to catch it when 99% of the nerve is alive and well, and we can slow that down. And for most people, they won't end up going blind as long as we catch it early. So who's at risk? In general, you can think of most glaucomas as a disease of aging. As we get older, that nerve can break down. So anybody over the age of 50, anybody with a family history of glaucoma, especially in a first degree relative, mom, dad, brothers or sisters, they have a significantly increased risk of getting glaucoma after the age of 50. If they have increased eye pressures on their screening exams for their annual exam, or sometimes if they have certain systemic medical conditions like diabetes, lupus, and rheumatoid arthritis, and if they're on steroids, but we're not going to talk about those kind of secondary types of glaucoma. So in general, there are many, many, again, different types of glaucoma. You guys don't have to know that all the different types, just know that there are different types and that you don't have to have high pressures to have glaucoma. And actually, the majority actually here in Hawaii do not have high pressures. But the most common ones that you're going to see are primary open angle glaucoma, which is kind of the age-related wear and tear of the optic nerve, and acute angle closure glaucoma. And you do not, again, need to know all of those different types. And so we'll talk now about, glaucoma because there's no cure. It's kind of like a difficult disease to treat. I think setting expectations with the patients in your office, they'll also ask you about different diseases such as glaucoma. It's a chronic progressive disease that you cannot cure, and it's going to get worse the older they get. If we get people's pressures low enough, some people are very lucky that the glaucoma stabilizes and doesn't progress. But because the glaucoma damage is irreversible, it's kind of like a quadriplegic not being able to walk again. We want to just try to diagnose it early and then treat it early, just to slow down the disease process to give everybody as much time with useful vision as possible.
In the healthy eye, fluid called aqueous humor is made in the front of the eye and flows out through a tiny drain called the trabecular meshwork. The trabecular meshwork is located in an area called the drainage angle. If fluid doesn't flow out of the drainage angle properly, eye pressure increases and damages the optic nerve.
So it's kind of like a dumbed down version of illustration of glaucoma. And I don't know if how many of you guys remember this from your USMLEs and your boards, but this is what a normal optic nerve should look like. So there should be a thick rim of nerve tissue here, like a thick donut with a small center. The center is kind of like the hollow space or the dead space of the cable, and that's the cup. And you want basically a small cup to disc ratio. This is again normal, and this is what a person with end stage glaucoma looks like. There's hardly any nerve tissue left here. This rim is kind of what we call cup to the rim, and there's this big excavated dead space in the center of the nerve. And you can see here as the cupping becomes worse, what the visual field deficits become, going from normal to the left and severe glaucoma with just a central island of vision to the right. And this is kind of what a patient experiences as the vision is getting lost from the glaucoma. But again, they don't see this big black area. The brain will project a virtual image in the areas that are black. And there's three different ways to treat glaucoma. There are medicines, which I'm sure many of your patients are on. You wish they probably weren't on, but they have systemic side effects as well. There are lasers, and last but not least, there's surgery. And so we'll briefly talk about all three of those methods. So in general, you can think of the eye as kind of like a toilet there, and I'm like a plumber of the eye, if you will. There's two main mechanisms to lower the pressure. We can either decrease the amount of fluid that the eye makes. So that's what the alpha agonists, the beta blockers, and the carbonic anhydrase inhibitors do. So we make less fluid, or we can work on the plumbing. We can basically do a rotor-rooter of the drainage systems of the eye and increase the drainage rate to decrease the pressures inside the eye. For the lasers, there are many different types of lasers that we have in glaucoma, but the one that you guys will encounter most commonly are basically something called a SLT, or a selective laser trabeculoplasty. And what that laser does is it takes less than 60 seconds. There's no pain. We shoot a laser in the drainage system called the trabecular meshwork of the patient, and it remodels the drainage system in 75% of the patients, kind of optimizing their own drainage system, possibly avoiding them starting drops or getting their pressures even lower if they're on drops. The laser peripheral iridotomy, that's a treatment for acute angle closure glaucoma. So there's a common misconception that, oh, I had an LPI and I won't get glaucoma now. Not really. So the LPI just prevents you from getting acute angle closure glaucoma from pupillary block, which is one super small rare type of glaucoma when the eye is like too small. So helps with the outflow of fluid, but it will not prevent you from getting glaucoma, and it won't actually decrease your pressures. Um, this is a video on SLT. And this is a super common first line treatment for glaucoma, especially in somebody that doesn't want to start their glaucoma drops. We numb their eye and then just put them at the slit lamp for the laser. And we treat about 180 degrees of their trabecular meshwork. It should help it remodel to allow the drains to work a little bit better. And surgery is usually always our last resort. And so if medicines and lasers weren't able to achieve the pressures that we wanted, then we can do different types of glaucoma surgeries. And historically, even when I was in medical school, there were just mainly two different options. There was the big gun glaucoma surgeries had tube shunts and trabeculectomies. And we'll go over kind of what those are now. But in the past decade, the whole realm of minimally invasive glaucoma surgery kind of exploded. A lot of the data that shows now that it's very safe to use, it's very effective, and now it's done before any of the traditional big gun glaucoma surgeries to buy us more time. And so in traditional glaucoma surgeries, in a trabeculectomy, what you see here on the left is basically we kind of remove the skin of the eye, and then we make a partial thickness scleral flap, and we'll hole punch a hole from the white portion of their eye going into the center of their eye, and then cut out a piece of their iris, and that will act as an external drainage system and create a bleb on the top. Um, and as you can imagine, that it is pretty invasive. The tube shunt surgery, we open up the skin of the eye, and we sew on an implant, and we track that implant into the front of their eye, again, establishing an extraocular drain. So this is me doing a trabeculectomy. And so I'll do a traction suture here, injecting an anti-fibrotic agent called mitomycin C in there. And then we're doing a partial thickness scleral flap here. And we want to get about 90% depth. And then we'll cut into the eye and use a hole puncher here. Well, it's called a Kelly punch. And then we'll stitch it back up. And that'll allow flow going from the inside of the eye to the outside of the eye. And it's very effective. It's really good in third world countries because you don't really need very many instruments to get it done. But the long-term complications of a trabeculectomy, they're potentially blinding. That bleb can get ischemic and thin and rupture over time. There's a lot of different things that kind of sets off like a ticking time bomb. So if we can avoid it, by all means, we will do everything in our power to avoid it. This is something called the tube shunt surgery, removing the skin of the eye here, and then getting a space between the superior and the lateral rectus muscles, and then stitching on the tube shunt with some partial thickness scleral sutures over here, about 7 millimeters posterior, and then getting a needle track into the front of the eye. And that tube will then thread into the eye and then basically take the fluid from inside the eye and release it onto that plate as an extra drainage system. And then we cover the eye here. But again, we want to avoid tube shunts as much as we can as well, because long term in the eye, there are, potential downsides for having this plastic tube inside your eye. It can degrade your cornea at a much faster rate. And now ushered in within the past decade, this era of minimally invasive glaucoma surgeries where we can stent open the drainage system, we can kind of rip open the gutter system and just totally remove it in itself. And there's stents of various sizes to fit the severity or type of glaucoma that you're treating. MIGS in general are safer. MIGS stands for minimally invasive glaucoma surgery. It can lower the eye pressures and possibly eliminate the need for some of the patients to be on medications or decrease the amount of medications that people are taking, especially if they're having systemic side effects, like somebody on a beta blocker, but they developed heart block, or they have AFib, or they have bad asthma. All of these glaucoma medications that we use, they do have systemic side effects. So sorry, ahead of time too, as I know the geriatric population has so many different health issues and want to try to get all the polypharmacy down, but each patient is unique in terms of what surgery is decided to do, on this patient. There are so many different types of glaucomas based on their starting pressures, their pressure goals, their rate of progression, that it's, our job as glaucoma specialists to pick which best minimally invasive glaucoma device, to put for their patients. So just for you guys, know that there are so many different options that we can do, that it's not that's like outside the traditional kind of higher risk trabeculectomy and tube shunt, that there's a whole bunch of different minimally invasive glaucoma devices, and that we commonly do them with their cataract surgery, or even if they don't have a cataract, we can still do the minimally invasive glaucoma surgery to get them off drops to decrease that burn-in. And it's not a one size fit all, but we can definitely point them in the right direction of what would work best for their eye. And so these MIGs, they improve the outflow from the eye. So it improves right here, kind of decreasing the barriers of resistance from fluid leaving the eyeball, working on the gutter system. So this is an example of something called a viscocannulostomy and a trabeculotomy. This is one of the procedures that I do quite often, but there are many different devices that accomplish the same thing. But what this does is it threads a catheter between the trabecular meshwork and Schlemm's canal, and it dilates everything, kind of like doing a roto-rooter. So you'll see that here. It'll go 180 degrees, and then after it dilates for 180 degrees, when this gets retracted, it shoots out a jelly called viscoelastic that will open up the venous collector channels that are kind of like the little pipes draining from the eye. So it kind of works on the distal outflow system of your eye, as well as working on your gutter system. And so after you're done doing that, you reinsert the catheter, and you can basically remove that gutter system, that barrier, that mesh barrier that gets scarred down as we get older, to again decrease another point of resistance of fluid leaving the eye to decrease the pressure. And that procedure takes maybe 30 to 45 seconds or so to do, less than a minute. This is a video of a viscocannulostomy and trabeculotomy. So the thing that you just saw, plus putting an eye stent in it, is just like a type of stent that goes inside the eye. So this is just kind of in real time. I already finished the cataract surgery, and so that dark line there is the trabecular meshwork, and inserting the catheter there, and then coming out to do the viscocannulostomy. And then I'll go 360 degrees. So I'll do the superior 180 here. And then ripping out the trabecular meshwork there, and then using It's a really cool device. It's like kind of like playing a video game. You point, you shoot, you click a button, and it fires the stent into the trabecular meshwork, and that'll permanently stent it open in the future. And so this is a larger stent called the Hydrus. I don't use this as much anymore. And again, I don't have any financial interest in this or anything like that. But you can see that this is a much larger stent working in the same area to kind of create a scaffold to uh, push that gutter system open and keep it open long term. And this is a combination of both of those kind of minimally invasive glaucoma devices where we're opening up the drainage system first with a viscocannulostomy. And then we're going to rip out the trabecular meshwork on the superior portion, the superior 180 here, and then place one of those other larger stents in the inferior angle. And so this way we can kind of mix and match different types of minimally invasive glaucoma surgeries to meet the pressure goals of the patient. So I'm going back in and then putting that larger stent in. And so, in summary, there are many, many types of minimally invasive surgical options and kind of like the big gun surgical options as well. MIGS can severe glaucoma as standalone procedures or combined with cataract surgery. It is not a one size fit all, kind of deal. Your glaucoma specialist can figure out which is best for their eye. But it is much safer than traditional glaucoma surgery, and we always try to do that before we go down the path of the traditional glaucoma surgery. That old adage, higher risk, high reward is definitely true for glaucoma surgery. You can get really good pressure lowerings from the minimally invasive stuff, but you can get really, really, really awesome repeatable lower pressures with the big gun glaucoma surgeries, but it comes at a cost of complications down the road. And one of the complications being potentially blindness. And so in general, what I want you guys to take home from our talk today about glaucoma is that it is not curable. It is an irreversible, chronic, progressive disease that will worsen over time, but most will not actually go blind in their lifetime. If you catch glaucoma early at the mild stage and you start treatment, 90% will not go blind during their lifetime. So diagnosing the disease early, treating it early will buy the patient much more time with useful vision, and many end up outliving any kind of blindness. So just diagnosing it early, treating it early, and there are so many good options, medicines, lasers, surgeries for us to treat this disease now. Every eye is unique and it should be tailored to each patient. And so now we'll do some question and answer, dispelling old wives' tales. I can't see any of your responses uh, or audio.
Did we have
Uh,
people put it into the chat?
I'm not. Oh, I can look at the chat. Okay, yeah. So true or false? Sitting too close to the TV will ruin your eyes. Anyone? Anyone brave? Oh yeah, some true, some false. Yeah, perfect. So actually, sitting too close to the TV won't actually ruin your eyes. That was false, but my mother told me that all the time when I was growing up. Your vision will get worse if you read in the dark. True or false? Yeah, my mom told me this as well. But believe it or not, it's false. It's just it's harder to read in the dark because your pupil dilates, and when your pupil dilates, more blue light wavelength gets let in, and that refracts in front of your eye, so you become effectively more nearsighted. So it changes the focal point, so it's a little bit harder to read in the dark, but it will not ruin your eyes. And true or false, wearing glasses makes your eyes dependent on them? Correct. Yeah, yeah, false. It just makes your vision better. Yeah. Wearing glasses with the wrong prescription will ruin your eyes. Yes. So yeah, agree. So yeah, false. So again, don't have to worry if the prescription is wrong. It's just going to be a little bit more blurry. But children are the exception to the rule. So if you have any child, especially under the age of 8, but also under the age of 12, they have to be in the right prescription because if they are not, uh, and one eye is a lot stronger than the other, the weaker eye will be ignored by the brain, and that's how you develop amblyopia or a lazy eye. So kids always have to have spot on good glasses. Adults, not so much. Your eyes are already developed. And true or false, eating carrots will make your eyesight better. Yeah, so false with a caveat. You do need some vitamin A for your eyesight for your retinal ganglion cells to work well. But we get that through our diet through other ways. You don't need to eat a lot more carrots, and it won't make your eyesight any better. Just being vitamin A deficient will make your eyesight worse. So thank you again for having me. Um, that's my office if you guys ever need me. And thank you, Dr. Masaki, for having me speak. Any questions?
Thank you so much, Mike. Do our audience have any questions? We have a small enough group that you can just unmute yourself and ask your question.
Yeah, don't be shy.
Hi, Dr. Yim. I have a question.
Yeah,
I'm Kelly. I finished the fellowship last year and now I'm doing primary care.
nice.
How concerning is it for patients with glaucoma to use Flonase and other inhaled
Oh
steroids?
yeah, so that's a great question. I would say the first generation of those inhaled corticosteroids, they had much higher systemic absorption, but now they do a much better job of keeping it more localized in that area. So the rates of steroid-induced glaucoma have significantly decreased. But in general, for steroid response, 10% of the population will have a rise in pressure with chronic use of steroids. So that's over 4 to 6 weeks of steroids. That's considered chronic. So if they're on it for more than a month, they are at risk. And that's the general population have a 10% risk. But people that do have glaucoma have an even higher risk to be raised. So it's not like you cannot prescribe corticosteroids for people that have glaucoma. You totally can. Just make sure that they follow up with their glaucoma specialist a little bit, or their whoever is monitoring their glaucoma, to monitor it a little bit closer, and especially to check the pressures about 1 to 2 months after the chronic use kind of started. So if you started in January, they should have their pressure checked sometime in February or so, February, March, just to make sure that they're not rising. If they don't rise by 6 weeks, usually they're not going to rise over time. Usually you're safe. You're not in the category of a steroid responder. But people that have really, really severe glaucoma, like super small vision left, and their pressure goals are really low, I would say it's rare, but I will sometimes ask the primary care doctor to not do the steroids if they are a steroid responder and they fall in that category of really poorly controlled glaucoma. But for people that have mild glaucoma, doing well on drops, most people are fine. So I would just ask about the severity of the glaucoma, and then if you start the steroids and you're anticipating them being on it for several months or so, just at like the 1 to 2 month um, point after you start the steroids, have them check in with their eye doctor to just get their pressure checked. That's a really good question.
Yeah, thank you. What about like short-term use of steroids, like if they have like a really bad cough or asthma flare and they need
Oh
to
yeah, minor. Yeah,
Yeah,
again,
okay.
like if it's over a month in general, that's the amount of time it takes.
All right. Thank you
Yeah,
very much.
so yeah, no problem. Medrol dose pack, totally fine.
Thank you. That's very helpful. Any other
Mhm.
questions for Mike? Give it one more minute. In the meantime, John, could you put the link to the evaluation in the chat? Oh, I see it already. Thank you, John. So don't forget, everybody, to get your CME credits, you do need to do the evaluation form. And please give us suggestions for future topics as well. Do we have any last questions for Mike? If not, Mike, thank you so much. I know you
No
have a
problem.
very busy schedule, and we really appreciate you talking to us on this very important topic.
No
It's
problem. If you
means
guys
a
ever
lot.
have
Yeah,
questions?
it's changed a lot since I went to medical school, the whole definition of glaucoma. So it was very nice to have an update.
Thanks for having me. If you guys have questions, you can email me or text me. People text me and email me all the time about patients, and so I just put my number and my email in the chat. So feel free to contact me. Take care,
And
guys.
if they have refer patients, they just call this number that's on the screen right now.
Oh yeah. My office number.
Okay. All right. Thank you so much, Mike.
Yeah, no problem.
Okay. Bye-bye. Take care.
Bye, guys.